Hi, good morning, good afternoon, good night, wherever you're joining us. Welcome to our 10th lecture. Before we start, it's been a couple of really sad days for our hemodynamic family, as yesterday we found that one of the cornerstones of modern hemodynamics is no longer here with us, Dr. Regan Giesinger. Regan was a great friend, an amazing teacher and mentor to a lot of us. She had an infectious passion on hemodynamics and transmitted to everyone around her. And she was really fun to be around. I don't remember any bad day, no matter the workload or how stressful the situation was. I used to call Regan boss when I was a fellow. And I remember one time, she was always ahead of things. She always knew when a baby needed her, and she was in the hospital 24/7. So I remember one day asking her, boss, how do you manage to do this? Isn't this exhausting for you? She told me something that really resonated on me, and I will keep it in my heart throughout my entire career. She told me, Daniel, our babies deserve the same care, the same level of care, no matter the time, the day, or even the person in charge of the baby. May her soul rest in peace, and may her soul guide us to make this a better world for our babies. Thank you, Regan, for all your work, and we will have a minute of silence. As Patrick told me yesterday, Regan is now a part of every hemodynamics program around the world. So thank you so much. For today's talk, we will have the fantastic Amir Ashrafi talking about nitric oxide for congenital diaphragmatic hernia, friend or foe. Dr. Amir Ashrafi is a neonatal cardiac intensivist at Chubb Children's Hospital with an interest in caring for newborns with hemodynamic instability and or congenital heart disease. He's the director of neonatal cardiac ICU and the clinical director of the neonatal ECMO program. He is also the co-founder of NeoHeart and initial president of the Neonatal Heart Society. And then for the panel discussion with Dr. Tina Leone, we will be joined by Dr. Gabriel Altit, who is an assistant professor in the Division of Neonatology at McGill University Health Center and staff neonatologist at Montreal Children's Hospital. He's the principal investigator of the NeoCardial Lab with research interest in neonatal hemodynamics and populations with congenital diaphragmatic hernia, congenital heart defects, pulmonary hypertension, and prematurity. We will also be joined by Dr. Maky Fraga, who is a professor in clinical pediatrics at the University of Pennsylvania and attending neonatologist at the Children's Hospital of Philadelphia. She serves as the director of neonatal point of care ultrasound program at Chubb, and she is the current chair of the National Neonatal Caucus Collaborative. And we will also be joined by Dr. Jason Jin, who is an associate professor of pediatrics and neonatology at the University of Colorado at the Children's Hospital. He has a basic science lab that focuses on the contribution of altered lung development to the development of pulmonary hypertension, and clinically has focused on congenital diaphragmatic hernia and ECMO with an emphasis on the transition from the intrauterine to extrauterine life. So thank you so much. Go ahead, Amir. Thank you.
Excellent. Thank you so much. Hello, everybody. Good morning, good afternoon, good evening from wherever you are. I want to first start by thanking Daniel for the introduction. Thanks to Lord Thomas and the NHRC for the invitation to speak here. And also thank you to the panel for being a part of this. I also want to give my heartfelt love to Dr. Regan Giesinger and her entire family. What I want to be talking about today is a topic that's become quite popular in recent times. Congenital diaphragmatic hernia. Is inhaled nitric oxide a friend or a foe? As you heard, I'm from the Children's Hospital of Orange County. And I do have one major disclosure, And that is, this is going to be different than most talks you guys hear in this forum. It's going to be more of an op-ed piece. We'll definitely present peer-reviewed, published data, but throughout, I'm just going to kind of insert my own personal biases and my own interpretation of the data for this complex patient population. I want to first start with the way I approached diaphragmatic hernia back in 2017 and earlier. I finished my NICU fellowship in 2012. And so after being attending for a few years, I recognized with diaphragmatic hernia, there's this triad that exists between the heart, the lungs, and the pulmonary vascular bed. And we would take each of these into consideration with regards to the lungs. We learned from the group out in Colombia, late 90s or so, maybe early to late 90s, the importance of general ventilation, permissive hypercapnia, limiting the volume trauma and barrel trauma that can take place with conventional ventilation, and quickly move to HFOV if needed. Of course, we knew that pulmonary vascular disease was a big deal, and we were always worried about pulmonary hypertension. We know that oxygen is a good pulmonary vasodilator, so I would always keep my saturations above 90%. And even though there was no great evidence to support the use of inhaled nitric oxide, I used it, and let's be honest, everybody used it as well. And that's in the face of some data that inhaled nitric oxide either has no benefit or increases ECMO or death. Now, again, none of this evidence was really all that, just wasn't that great. So everybody continued to use it. And really, pulmonary hypertension and right heart failure was the primary reason most of these kids would go on ECMO. And then when it comes to the cardiovascular component of it, I was very blood pressure centric. If the blood pressure would drop, dopamine, epi, and ultimately, if needed, hydrocortisone. This was sort of my paradigm, 30,000-foot view paradigm. And in all honesty, it was just as simplistic as this slide looks. This is really, quite honestly, what I was taught by my attendings and what I thought. And at which point I would then make one of two phone calls. I would either call my surgeon and say, hey, this baby's in a good place, PVR's dropped, let's go for repair, or this baby's not doing so great and we need ECMO. However, everything changed for me in 2017. You guys heard that one of the co-hosts of NeoHeart and my good friend and mentor, Dr. John Cleary, was in charge of the abstract session in 2017 NeoHeart. And he calls me up one day and he says, hey, have you ever heard of this guy named Gabriel Altit? And I kind of think to myself, Gabriel Altit? No, never heard of him. Who's he? Well, he's this fellow out of Stanford who seems to think that in babies with diaphragmatic hernia, their left heart performance is more indicative and more important for indicating who's going to need ECMO compared to the right heart. And I kind of thought about it for a second. I was like, well, that's dumb. No. It's really good. You should read his abstract. So I read his abstract and it actually was very good. And he ultimately won the Abstract of the Year award that year. Well, fast forward about 24 to 48 hours, ultimately led to a publication. Fast forward 24 to 48 hours, a good friend of mine, also a mentor, Dr. Gil Warnofsky, cardiac intensive care, spent most of his career at CHOP, is currently in DC. This was one of the first NeoHearts we had done. Maybe it was the second, or I think it was the second, maybe third. And so I was still new at this. And I went to Gil and I said, hey, Gil, I'm still kind of new here. How's the meeting going? What do you think? Can you give me any constructive criticism? And, he said a few things and he said, what would be really awesome is if you had a session on comparative physiology, looking at the physiology that takes place in the neonatal world and the cardiac ICU world and where things overlap. I said, okay, well, what do you have in mind? He's like, maybe hypotension, maybe cooling, maybe this, maybe that. But really, what about diaphragmatic hernia? I mean, babies with diaphragmatic hernia are essentially like babies with Schoen's complex. I mean, they're basically the same thing. He then goes on and starts talking, and I'm nodding my head because, he's such a smart guy and I don't want to look like an idiot in front of him. And I'm nodding my head, but I'm thinking to myself, diaphragmatic hernia and Schoen's complex, what is this guy talking about? I just couldn't wrap my head around the fact that diaphragmatic hernia has any sort of similarities to Schoen's complex. He continued to talk for another few minutes. I heard nothing what he said afterwards and just left perplexed. Well, let's fast forward a couple more days. I'm now back in the unit and young resident, Dr. Sharif Jafar, his mom's a neonatologist. Currently, he's a pediatric cardiologist. He comes up to me and he says, hey, Amir, I'm thinking about future in neonatal cardiology, but I want to come from the cardiology side, not the neonatal side. Do you have any research for me? I said, interesting, you should mention it. There was a fellow out of Stanford who had some pretty compelling data that left heart performance is very indicative of those who can need ECMO for CDH. We should go back and look at our data set over the last 10 years and see if we can replicate it or not. And sure enough, it was identical. The severity of pulmonary hypertension or right heart failure had no bearing on the incidence of ECMO, but left heart output was statistically significant for those who were needing ECMO. And so as I'm looking at this and I'm trying to think, it didn't really make sense early on. Ultimately, we published this as well. But the more I thought about it, it started to make sense. And it has to do with altered blood flow throughout gestation. We know that in a normal baby, you have approximately 90% of your blood that gets shunted right to left at the level of the ductus, which means about 10% goes to the lungs. That 10% comes back through the pulmonary veins and ultimately volume loads your left heart. However, in babies with diaphragmatic hernia, and the more severe the diaphragmatic hernias, the higher your PVR is, you're going to get more shunting right to left through the ductus, which means you're going to have less blood going through the lungs, which means you're going to have less volume loading of that left heart through 9 months gestation. Now, all of us have also heard that babies with liver up tend to do worse and have a higher incidence of ECMO than those who have liver down. And so the reason for that wasn't quite intuitive to me. It wasn't apparent to me in the beginning. But the more I thought about it, we know that blood that's coming through the ductus venosus is shifted towards, moved towards the left heart through the PFO, which approximately 70% of blood coming back from the placenta volume loads the left ventricle, only about 30% goes to the right ventricle. However, in these babies with right-sided diaphragmatic hernia, and again, particularly the severe ones, or those who've got a liver up position, what it does is it changes the three-dimensional configuration of your ductus venosus. So now that it's angled and is pointed directly towards the tricuspid valve, not the PFO. So what ends up happening in these cases, you then have volume loading of the right ventricle. You do not have volume loading of the left ventricle. And so throughout 9 months of gestation, they get reduced preload to their left side based on altered ductus venosus flow, as well as altered ductus arteriosus flow. And we know that from hypoplastic left heart data, that left ventricle growth is dependent on volume. It is not dependent on pressure. So it started to make sense to me what Gil was talking about just earlier than that maybe diaphragmatic hernia does have a lot of components of Schoen complex. And we know Schoen's complex can be a spectrum from either mild disease to severe disease, what's ductal dependent. It can be so far as it can be single ventricle physiology. And I'm not talking about the most severe cases of Schoen, but some of the mild cases of Schoen, absolutely. And we've known over 40 years now that babies with diaphragmatic hernia do have smaller, stiff left ventricles. So it's starting to make sense. And if you go into PubMed and you take a look, there have now been 5 papers that I could identify that look specifically at left heart function in babies with diaphragmatic hernia, and all of them has showed statistically significant correlation between reduced either LV function or reduced LV output and the need for ECMO. So the question is, why is that? Well, it could be most obviously smaller left-sided structures, similar to Schoen's complex. They get decreased cardiac output. This decrease in cardiac output leads to an imbalance between your oxygen delivery and your oxygen demand. You get end organ dysfunction, lactic acidosis, and ultimately this is what triggers these kids to need ECMO. However, while there are similarities between CDH and Schoen's, we know that there's one major difference, and that's, of course, what happens to the lungs and the pulmonary vascular bed. So I want to focus on the pulmonary vascular bed for a second. And if we look at a newborn, there are 5 basic physiologic reasons why any newborn is going to have pulmonary hypertension. Just about anything can fit into one of these 5. The first one, and by far and away the most common in the field of neonatology, is this concept of hypoxic vasoconstriction. And in babies specifically with diaphragmatic hernia, we know that they too can have a component of hypoxic vasoconstriction. This is the physiologic subtype that is most amenable to pulmonary vasodilators and specifically inhaled pulmonary vasodilators. So this is what you see in your meconium aspirations, and these are the ones that fare so well. However, in transitional physiology with the baby with CDH, they too can have hypoxic vasoconstriction. Here's a study, a good study from CHOP that shows that they can be responsive and have good outcomes to inhaled nitric oxide. However, that's by no means the only physiologic reason these babies have PH. They also have a component of pulmonary vascular hypoplasia. Now, I don't need to tell anybody in this room, there's no amount of inhaled nitric oxide that's going to grow blood vessels. So this now becomes a fixed or a static pulmonary hypertension. We also know that they have abnormal vasculature. Their muscular layer of their pulmonary arteries are quite hypertrophied. And so when pulmonary arteries when the muscular hypertrophies, it doesn't hypertrophy out, but it hypertrophies in. As it hypertrophies in, you get a reduction in your internal diameter, leading to higher PVR. Again, no amount of pulmonary vasodilators is going to lead to muscle atrophy. So again, this becomes a fixed pulmonary hypertension. But the more we look, the more we're starting to find that there's also a fourth cause of PH in these babies. And none of these are mutually exclusive. They can have any iteration or any combination of all of these. But in the severe diaphragmatic hernia, those who do have compromised left ventricular size, structure, function, those that do have elevated left ventricular end diastolic pressures, they'll have a component of left atrial hypertension, which ultimately leads to pulmonary venous hypertension as well. And this is one of those physiologies that the more we look, the more we find. And so if we go back to these 5 papers and try to come up with a plausible explanation for why left heart function, depressed left heart function leads to an increased need for ECMO in the CDH population, there could be an alternative hypothesis that it's not necessarily compromised systolic output, but it's compromised diastolic function in these small, stiff left ventricles that lead to an increase in your left ventricular end diastolic pressure. That leads to an increase in your LA pressure, leads to an increase in pulmonary hypertension. And it's that combination of pulmonary arterial hypertension and pulmonary venous hypertension that ultimately requires these kids to go on ECMO. Now, this, up until recently, was just a theory, and there was no great evidence to really support it. And in fact, before I go there, let me just jump in here. So this plays into the fact that why nitric oxide, this plays into the question, where is nitric oxide helpful or harmful? We know from adult data, we've known for decades now, that the worst thing you can do to an adult with left heart diastolic dysfunction is to volume load that LV. So whether you volume load it with boluses, whether you volume load it with pulmonary vasodilators, in a left heart with diastolic function, they cannot tolerate that volume load. You get worsening pulmonary edema, and ultimately, worst case scenario, you can have death. So this is why people start to ask the question, well, is inhaled nitric oxide in this physiologic subset a good thing or a bad thing? We never really had any good data until a paper that just came out about 2 months ago. I want to give credit to the Congenital Diaphragmatic Hernia Study Group. They published this in February of this year. Early nitric oxide is not associated with improved outcomes in congenital diaphragmatic hernia is the title of this paper. This was an international consortium, prospective observational study spanning 5 years, looking at the use of inhaled nitric oxide over the first 72 hours of life. They enrolled an impressive number of 863 newborns. And they're jumping to the results, there are 2 patient populations that I want to highlight. Now, the one great thing about this paper, very well written, clearly an incredibly bright group of authors. It was very nuanced in the writings, in the results, in the discussion. They did a phenomenal job. And there was 2 patient populations they highlighted that I want to highlight here. They looked at babies who have they performed echoes of babies with diaphragmatic hernia, found that their PDA shunt is all right to left, meaning that their PVR is higher than their SVR. And at the same time, their PFO or their atrial shunt was all right to left, which would indicate that their right ventricular end diastolic pressure is higher than their left ventricular end diastolic pressure. In other words, those who got high pulmonary vascular resistance, but no obvious signs of diastolic dysfunction on the left heart. On the flip side, there was a second group they looked at, those again with pulmonary hypertension, those whose PDA was all right to left, meaning that their PVR was higher than their SVR, and their PFO was now reversed. The shunt was left to right, indicating that their left ventricular end diastolic pressure was higher than their right ventricular end diastolic pressure. In other words, pulmonary hypertension with diastolic dysfunction of the LV, most likely. And so if you were to look at these 2 groups in particular, and if I were to plot it out, potential benefit versus potential harm, you would suspect in that first group, they've got pulmonary hypertension, but they don't have any obvious signs of LV diastolic dysfunction. So I would say that their potential for benefit is high, their potential for harm is low. This is the patient population you would want to use nitric oxide on. But what they found was quite interesting. excuse me, when they used inhaled nitric oxide in this patient population, the risk for ECMO went up a nearly statistically significant amount, and their mortality went up to a statistically significant amount. So there was no benefit, but substantial harm. Now, on the flip side, the patient population that you think would have, again, some benefit, but potential for harm. They have diastolic function. These are the ones you don't want to give nitric oxide to. If they do have a dynamic component to their pH and you vasodilate it, that's just going to ultimately lead to more volume to the left heart that it may not be able to tolerate. But interestingly enough, there was no difference in mortality. There was no difference in ECLS. So truth be told, as much as I did enjoy reading this paper, as much as it was incredibly well written and nuanced, and obviously the authors put a tremendous amount of thought into this, I don't know what to do with the results. It just doesn't make sense to me. And I'm interested to, in the group discussion afterwards, to see if anybody else can shed some light. I don't know what to do with this paper, and I don't know how to incorporate this into my everyday practice. However, let's put that aside for a second. This brings up a bigger conversation. While nitric oxide may be harmful, may not, I think there's one thing that all of us who take care of neonates with congenital heart disease must wrap our head around, and we must change our thought process on, is that CDH is more than just optimizing ventilators, optimizing pulmonary vasodilators. There's a tool in our armamentarium that doesn't get used often enough, and that's prostaglandin. Whether your physiologic rationale is compromised systolic function or compromised diastolic function, PGE would be the ideal choice. When you look specifically at the left heart, it can maintain the maintenance of ductal patency will allow for stable circulation, i.e., it'll improve cardiac output and supplement your systolic function. On the flip side, it will prevent and volume load to an LV that can't tolerate it. So it will preserve any diastolic burden you have on there. And there is a growing body of literature in the recent years that PGE may be a very good drug for patients with severe diaphragmatic hernia. But let's not just focus on the LV. We know that the RV, of course, is an important part of babies with diaphragmatic hernia. Now, this has been discussed multiple times in this forum at NHRC and multiple talks, how the neonatal RV is distinctly different than the pediatric, and most certainly the adult RV. So I'm not going to spend too much time. I also know that some of our panelists are on service, so I don't want to spend too much time. This has all been discussed before. We know from a macroscopic and a microscopic point of view that the RV is just more sensitive to high afterload states. I don't want to spend too much time there. Let's just get to this. So my bias until 2017 again was these babies who go on to ECMO. The reason they go on to ECMO was because of pulmonary hypertension and RV failure a significant percentage of the time. But if you go to the data, that doesn't bear out. There's no great evidence that RV failure or pulmonary hypertension is the primary reason why these babies need to go on to ECMO. So I want to insert here, again, I talked about Dr. Warnowski and how he's a good mentor of mine. He always has these 3 rules of hemodynamics that apply to just about every neonate you care for, whether it's a baby with ASD or it's a baby with hypoplastic left heart syndrome. And the first is, if there's a hole between 2 chambers, the pressure will equilibrate. Number 2, blood always travels downstream. And number 3, a blue baby is better than a gray baby. These rules apply in all circumstances. So now if we back up, and I'm trying to convince everybody here that severe CDH is a ductal dependent lesion. Well, the maintenance of the PDA, while it helps the left heart, well, what does it do for the right heart? I don't think in 2023, any baby should go on to ECMO because of right heart failure. We know that in utero, their right heart was conditioned to seeing systemic pressure for 9 months, and they did just fine. When these babies fail postnatally, the ductus closes. The RV is now, again, those with severe disease, seeing suprasystemic pressures. That's when the RV fails. As long as we keep the duct open, it allows a pressure pop off. The RV will never see anything more than suprasystemic pressures, and therefore the RV should never fail. If the RV fails, I'm going to go so far as to say not all the time, But in many circumstances, it's the neonatologist or the bedside caregiver who's not paying attention to the hemodynamics of that patient. Now, I said that this talk is a bit of an op-ed piece, and in our NICU back in 2017, we decided that, you know what, we need to completely rethink our approach to CDH, and we need to be better for our babies. So what do we do? Again, I don't know if it's the right way, I don't know if it's the wrong way, but it's our way, and we've had great results with it. Well, like I said, there's the triad of the heart, the lungs, and the pulmonary vascular bed. There's going to be a subset of patients who have severe lung hypoplasia, respiratory failure. I think all of us are very keen on gentle ventilation. We don't need to spend too much time on this. We'll do everything we can. And ultimately, if you can't get adequate ventilation, these kids need to go on ECMO. Again, I think we're all good here. We don't need to spend too much time on lung mechanics in babies with diaphragmatic hernia. However, in babies with PH or RV failure, I think this is an area that we can and we must do much better. At our institution, we do serial echoes. And in fact, we do echoes in these babies sometimes 2, 3, 4 times a day. And we'll get serial echoes. If a baby with a CDH has an all left to right shunt through the ductus arteriosus, that would indicate that your PVR is lower than your SVR, which means your pulmonary vascular hypoplasia, pulmonary vascular disease isn't that bad. Chances are this baby's going to do just fine and will continue with traditional care. However, there's going to be some babies that have this pattern where they've got bidirectional flow through the ductus arteriosus. These are the hardest to predict. You can say at least they have systemic pulmonary hypertension. They don't have super or under systemic. At the very least, they have systemic. And in these cases, it is not unreasonable, in our opinion, to start these kids on inhaled nitric oxide. Now, again, inhaled nitric oxide is not going to fix, let me say that again, it's not going to reverse fixed pH. But if there's a component of a dynamic pH, if there's a component of hypoxic vasoconstriction and transitional physiology, nitric oxide can help there. However, it is beholden upon us to monitor the downstream consequences of inhaled nitric oxide. The example I like to give when talking with our trainees is that if a baby's got acute renal injury and you give vancomycin and the kid goes from acute kidney injury to acute kidney failure, it's not that vancomycin is a bad drug and you should never give vancomycin and we must discontinue vancomycin from the NICU. No, every drug has a therapeutic threshold, but it has a therapeutic window and has a toxic threshold, and it's beholden upon us to monitor the consequences of all the drugs we give. And inhaled nitric oxide, while it will pulmonary vasodilate some patients, there's going to be downstream ramifications, and we need to monitor those downstream ramifications and be ready to make adjustments if they occur. In addition, as this duct closes, again, we don't know exactly what's going to happen here. Is this PVR going to be so high and cause so many problems that now you burden that RV? If that's the case, we need to monitor these patients very closely. Otherwise, you're going to have a scenario like this, where as the duct starts to close, your shunt goes all right to left. Clearly, they've got super systemic pulmonary hypertension. These are the babies that will acquire right heart failure. Any pulmonary vasodilator isn't your answer, it's prostaglandin. This baby was doing fine beforehand, reestablish fetal circulation, volume, and pressure offload that RV. PGE is the most important drug in this scenario. And we've seen this several times, and we've been able to avoid ECMO quite nicely with the fact that we've been able to reestablish stable circulation. And with growing evidence, there's the cardiovascular implications of diaphragmatic hernia. This concept that they can have a low cardiac output state and or LV diastolic dysfunction. And when we look at these guys, how does it manifest at the bedside? They'll have low cardiac output, systemic hypotension, they'll have narrow pulse pressures. They also have hazy lung fields, which can sometimes be difficult to appreciate in babies with diaphragmatic hernia. Up until 2017, I'll tell you, I was guilty of being the person that would just, if they were hypotensive, volume, which of course we know isn't great in a baby with diaphragmatic hernia, flooding those lungs, you're not helping the baby, in which case I would just go ahead and start giving vasoactive support. And if those two didn't work, I would then go on to ECMO. But today in 2023, we need to be much more nuanced. We need to recognize the impact that the CDH has on the left heart. In my mind, I do agree with Dr. Gil-Warnowski. It does have a lot of similarities to Schoen's complex. And in these patient population, PGE can be vital. So just to review, PGE can pressure offload the RV, can maintain circulation in the LV that can't maintain output, and it volume offloads the LV that may be susceptible to diastolic dysfunction. So it can help in multiple ways. And so whether you do decide, I'm sorry, let me back up a step. One thing that now this is just anecdote, there's no real science to support this, and I'm looking, if anybody's interested, I'm looking to do this. I personally think the combination of inhaled nitric oxide and prostaglandin is probably the best combination in this patient population for all the reasons I just stated. And then if that doesn't work, if you need to give volume, then let's give volume. Then let's be a little more nuanced in the vasoactives we give. I think this is, again, has been discussed quite extensively in this forum. Which vasoactive medications are good for this patient population and which are not. And then and only then can we go on to ECMO. So my conclusion for this talk is that INO is not the answer for treating pulmonary hypertension in newborns with diaphragmatic hernia, but I don't think it's the enemy either. I think INO must be part of a larger therapeutic strategic approach to these babies with severe CDH. We must recognize that there are multiple physiologic subtypes of pulmonary hypertension, and they are not mutually exclusive. Any one patient can have at minimum 2 or 3, if not 4 different physiologic subtypes. So it's beholden upon us to try to tease that out. In those babies with a fixed component of pulmonary hypertension, pulmonary vasodilators are likely not going to be helpful. No amount of nitric oxide, sildenafil, Remodulin is going to grow blood vessels. That's not going to do anything. However, in the dynamic component, pulmonary vasodilators can be life-saving if used, and the important key is monitored appropriately. Newborns with congenital diaphragmatic hernia, I hear this all the time. This baby with CDH got really sick and required ECMO because of PH or RV failure. We hear it all the time. I've been guilty of saying it in the past. And to be honest with you, I sort of take issue with that. I don't know if these babies needed ECMO or received ECMO. If we're going to sort of be blind to advanced hemodynamics and not really recognize why they were so stable in utero, why they were so stable immediately post-op, but then failed day 2, day 3, day 4. I don't know if they necessarily needed ECMO, but they received ECMO. And I think it's upon us to be better, acquire higher level understanding of RV, LV mechanics, and choose our therapies appropriately. It's important to manage the LV in these babies with severe CDH just as importantly, or just as vigilantly as we manage their lungs. We're all in the neonatal world very good at managing the ventilator and lung disease of CDH, and we have to acquire that proficiency with the LV. In my opinion, I think this is the biggest take home. If I could, and again, I'm interested to hear what the panel thinks about this, and I'm interested to see if they agree or disagree. I think the biggest takeaway that we need as a community need to embrace is that CDH should be, severe CDH should be considered a ductal dependent lesion, similar to Schoen's complex and similar to other diseases I stated before. And this is probably the most controversial statement. I genuinely believe that state-of-the-art management of high-risk CDH patients does require the ability to perform targeted neonatal echoes multiple times a day. Similar to, again, the example I say over and over again, my cardiologists are fully on board with this, but initially, many cardiologists are not on board. They do get nervous and none of us would make a change on a ventilator. Or let me say it differently. All of us would make a change on the ventilator and get a blood gas 1 to 2 hours later to make sure that those changes yielded the results we want. So why is it any different in these babies with hemodynamics? If we're going to start PG, if we're going to start a vasoactive med, if we're going to give normal saving volume, we want to be able to assess if what we did was helpful or not. So I do think that this is important. I do want to put out there that we currently at our institution have 3 attendings and a 4th-year fellow who can obtain targeted neonatal echoes 24 hours a day, 7 days a week, which is exceptionally helpful. As we're growing our program, if there's anybody online, we are absolutely looking at Children's Hospital Orange County. We're looking for 2 neonatal hemodynamic attendings and any neonatal CBICU attendings. So if anybody's interested, please reach out. And so we followed the lead of Dr. Regan Geisinger. We too have developed a fourth-year fellowship here. So if anybody's interested, if there's any trainees, our application portal will open soon. Just feel free to reach out to me personally. I'd love to chat with anybody. I said it before, I'll say it again, with love to this beautiful person, to her Iowa family, to the hemodynamics community as a whole, and of course to the Geisinger family. Much love. You'll be missed. And with that, thank you all for your time.
Thank you so much, Amir. That was such a great talk. I wanted to start out by checking in with Gabriel and Maky about sort of first reactions and, you know, and your impression of Amir's approach.
Yeah, I can start if you want, Gabriel. That's okay. Well, I think you gave a fantastic talk. The way you recap all the history starting back from the Ninos trial, right, back in 1997. I have to say, first of all, that after treating so many infants with CDH for many years now, I can say that these infants have a physiology that humbled me all the time. Even when you think that you understand where they're going, they surprise you, right? And you have to be chasing them all the time. But I think the more we know and the more data that we see, I mean, all this growing data that have been coming out in the past years, the more kids we treat, the more questions, right, we have about all these, like nitric, yes or no? Yes, and when? You know, early or wait a little bit longer. So we still don't know, but I think we've made so many progresses from, you know, that Ninos that showed us for the first time, I think, that infants with CDH on nitric were requiring more ECMO, and that was the first question: what's happening? But we got to learn that infants with CDH have many complexities, as you presented, and up to now that we are qualify, like we are characterizing them as the different phenotypes, or calling them, you know, that's these patients have an RV phenotype or an LV phenotype or a mixed phenotype. And after all, I think, as you said, Amir, the most severe cases, they're all mixed phenotypes. It's everything together, right? So what to tackle first? That's the problem we have all the time at the bedside, right? And besides that, these kids with severe CDHs, as you said, should we consider ductal dependent lesion? Yeah, probably yes, because they are most of them born with left heart hypoplasia, even, you know, aortic arch hypoplasia. So they really became very, very complex. But I think we are understanding them better and better. And in fact, we have improved the survival quite significantly over the past years. So Gabriel, I mean, you can talk a little bit, and then we can keep that in. Yeah, I don't want to take over.
I think Maky really summarized a lot of all my thoughts. Well, first, I want to thank Amir, who really outlined so spectacularly the evolution of the science and the hemodynamics of CDH, and really outlined like kind of the core elements, both what we know and kind of the large knowledge gaps that we have to go forward in terms of the community. I also want to take a pause to really outline, you know, the incredible work that Dr. Geisinger has brought to the field of hemodynamics and our understanding how these babies, you know, how we need to be humble when facing these babies, and the core concepts that we believe to be kind of so ingrained in our mind. And actually some of these babies challenge these concepts and allows us to push us in science. And I think Regan really was, you know, a contributor to the building and development of the field of neonatal hemodynamics, and I think her memory will be with us forever. So my thoughts is that I also agree with a lot of what Maky just outlined. These patients, you know, they change in time. I think some of the publication you outline, Amir, is you know, tries to grasp the complexity of how each of these babies will go through their entire stay in their NICU, but really look sometimes at only one time point to actually predict what's going to happen to them, which is very dynamic, as you mentioned, and as Maky mentioned, these patients change over time. And so I do agree that some of these patients are actually presenting physiologies that are PGE dependent or ductal dependent. And actually when their ductus closes or becomes restrictive, they struggle depending on if they have more of a right or left-sided concern or mixed concern. So I do think there's still a large, amount of science to be built about how to use intelligently the use of PGE, for example, in some of these patients, the modulation of the duct, when to start it, when to stop it, who it will benefit or not. Will it prevent ECMO? Will it just accelerate, or will it prevent ECMO, or will it just delay ECMO? Will it prevent mortality? Will it help stability during ECMO? So there's many of these things that I think we still don't know about these patients. But I think you really, was right on about every single aspect that you outlined. I love the 3 elements of Dr. Gil-Warnowski. I think I took a screenshot. I'm going to show it to everyone. I think they're great. So these are my immediate thoughts on the subject. So really, thank you. That was a really fantastic presentation.
I want to just build on that one thought for a minute, based on one of the questions in the Q&A that came in, which is the idea of it being a ductal dependent lesion is a great way of thinking about it. But would you use PGE even if you already have a large wide open duct? Do you think that there's a role in that case?
I don't think so. I think if you have an open, unrestricted duct, now you can make the argument that PGE is also a pulmonary vasodilator, so you're just giving a second once a cyclic GMP. If you're doing nitric GMP versus AMP, you're doing a different mechanism. But I don't think that's the primary benefit of PGE. So if the duct is already open, I don't think there's any value in it personally.
Yeah, I agree 100%. And that's the beauty of having, of being able to perform echocardiograms so frequently, right? Because you can monitor that. And whenever they are starting to become restrictive in the presence of severe RV failure, then for sure.
Dang. I won't repeat.
Great. It's good to have consistency.
I think one thing, if I can just build on the PGE and the fact that these patients have a mixed picture, at least locally, and I don't know if it's been published or described, but we've seen some patients where the duct became restrictive and they started presenting a more decompensated picture of more profound hypoxia, possibly more right to left shunting at the atrial level because their RV was struggling, as well as being more, poorly perfused because potentially their preload to the LV was, impacted and their LVO was diminished. And once we start PG, we've seen some of these patients rescued, and eventually they do transition and they do go into like a bidirectional or eventually even a left to right. And I think for me and maybe for many, but I think that, for us, our approach has been that once we see this transition occur, that's when we have to start thinking about, peeling off the PGE layers while still monitoring them to see that they don't revert into the previous physiology. Because my concern with PG is obviously, it's still that you're opening a duct. So once you're going to have this balance that's going to change, are you going to contribute to pulmonary edema? Are you going to contribute to decreased diastolic pressure? And then we know that they might have some impaired coronary oxygenation. So are you causing issue with coronary oxygenation and steal from the coronary? So there's always that concern that when we start PGE, it's like almost like, okay, well, we're a bit tight because we want to make sure we monitor them closely to avoid getting into that cycle of actually over circulation, which sounds a bit counterintuitive because you think CVH, you think high PVR, you don't think over circulation, but we've seen some of these kids transition and we've seen some of these kids actually revert eventually to another phenotype. And that's where we've been, like, at least on a clinical basis, cutting our PGE, monitoring them to make sure they kind of revert back. They don't revert back into the previous more RV high PVR phenotype. So I would love to hear if you use PG in your center for some of these severe cases with shifting physiologies. What has been your approach? Is it that you just keep the PG until like they're corrected and you're like a week after that, or are you more kind of like on a daily or daily reevaluation to see what to do with these PGEs?
Excellent question. So we do echoes quite routinely. Once the duct is all right to left, they come off prostaglandin. If that's what they went on to it for. The other thing that you mentioned that I think is key is kind of slowing down. When you have a baby who's all right to left, and to your point is crashing, hashtag rule number 3, blue is better than gray. So if you open the ductus, now you've got this widening pulse pressure between pre and post. Everybody wants to panic. Oh my God, I got a gradient of 15, 20 points. No. Blue is better than gray. It's okay. Calm down. The kid's NPO, his intestines have got no oxygen requirement. His toes don't need any oxygen. Below the ductus, you're fine. Keep your hemoglobin high, monitor urine output, check lactase. You're going to have a gradient. That's why you put the PGE on and just kind of slow down. As long as the brain is seeing what it needs to, you're in a good place. So both of them, when it's all right to left, you don't need it. If it's all left to right, you don't need it. If it's all right to left, then expect a gradient and don't panic.
There's some question regarding the timing of these interventions, because a lot of times they can save the baby to go to ECMO, but is there any echocardiographic predictors that we know, like low LVO, or is there anything where we know we should stop doing prostaglandins, like all this new approach, and go straight to ECMO? Because there's some concern in the question of making it longer, and then ECMO won't be as effective.
Sorry, I was with you until that last part. Make it longer so ECMO is not effective.
Delay. So with a lot of these things, we're delaying ECMO. There's a bit of concern in the question, like how is there a timing for trying PGE, and that's my question is in terms of echocardiographic prognostic indices, or something that we can know that this baby needs to go straight to ECMO, or if we fix these parameters, we can be pretty sure that we can fix this baby without.
So 2 parts. So excellent question. If the kid needs ECMO, the kid needs ECMO. Don't mess around. If the kid needs it, he needs it, or she needs it. That's end of story. Predictors. There's no science. So everything I'm going to tell you again, I started by saying this is an op-ed piece. Here's another op-ed answer for you. There's no science to support this. If we have evidence of an RV that's facing too much afterload, that it can't tolerate it, if we have an LV that doesn't have enough cardiac output, or if we have signs of LA hypertension in the setting of a restrictive closing duct, then we will use PGE. So when's the right time? Whenever it's necessary, whenever we think there will be benefit, whenever it'll help the RV or LV. But to your point, you know, if the kid needs ECMO because of lung hypoplasia, for example, and just CO2s are 100, don't waste your time with PGE, just go straight to ECMO. But if you think that it's, I don't know, systemic perfusion and creeping lactic acidosis in the setting of a constricted duct, I might be able to improve my systemic perfusion. And in that case, it may be worthwhile to do it. This is why ChatGPT will never replace us. It'll replace radiologists and pathologists, but it won't replace us.
Yeah, sorry, Gabriel.
Go for it. No, Maky, please.
No, going back to the question, I think what the question is, you know, how much would you try, how much longer would you try before calling it, right? Like, it's always that discussion. I mean, should we stop here and put the baby on ECMO? Should we just wait a little bit longer and try, you know, 3 more hours or something like that? And if there is any sign on the echocardiogram that can tell us, okay, well, let's call it, this is it. I don't think it is, well, I am sure it's not that clear at all. And it's always a discussion about when to call for ECMO, right? But what I think we know is that if we have severe LV dysfunction, the likelihood of needing ECMO is higher. And I think that that's good data that we have, right? Same thing, you know, biventricular dysfunction. We also, well, Gabriel, you can talk about that because you published that, right? The performance and the need for ECMO. But what I think is also important, and this, I think it's a paper that's going to come up soon in Journal of Pediatrics, is also, the very sick kids that we see right after birth. We look at them with echo, we see biventricular dysfunction, severe dysfunction. And, we pay more attention to the LV currently because we want to decide nitric, non-nitric, what to do, how, what drug we're going to use. So when we see this biventricular dysfunction, sometimes after starting an inotrope, whatever, to support the LV, we see some kids that within 2 hours, they recover the LV function. They get better like that. And those kids then usually, this is a little bit of my opinion, as you said, because I don't think it's been published, but those kids usually tend to do better and get better. But when you come back day 2 and on your echo, still the kid has severe LV dysfunction or biventricular dysfunction, usually, I think it's also how long and how persistent the ventricular dysfunction is. I think that's a very important prognostic factor we should look at.
I so agree with you, Maky. If I can build on this, I think, going back to the question, which is, I think the $1 million question is like, oh, when do we put on ECMO, right? So, and if you go to different institutions, although we probably all follow the ELSO criteria and we all have the same kind of approach, or we think that we have all the same approach, I think there's different thresholds based on the experience of different teams. And that's why we're teams. And I don't think there's a right or wrong recipe. I think, it's for us as a community to get together and explore these different questions to get as much as possible the best answer for these patients. Now, to build on what Maky just mentioned, in patients who already have signs that there's organic hypoxia or ischemia. So we mentioned how, the gray baby, right? So the gray baby is a concern because you're leading to, tissue hypoxia, lactic acidosis, and worsening of your body function. Are you going to necessarily try to rescue the phenotype for hours and hours and days at the expense of possibly creating brain injury and organic injury? And I don't know that, many drugs will help rescue that phenotype. So I do agree that we see many patients that arrive with various degree of LV or RV or biventricular dysfunction, and that we're able to rescue their phenotype within a few hours. But in these kids that are persistently deteriorating despite these interventions, you have to get ready to go on ECMO, because I think that, the cost of not doing so is obviously creating more injury and hypoxia. And sadly, I'm not sure that there's like a one single echo metric, but rather the evolution of the patient in the bigger picture once you intervene. Also, talking about this concept of ductal dependency, I do think that some babies who have a smaller ductus or restrictive ductus, or who are worsening as their ductus are closing, tend to be better responder than if you take a baby who has a large ductus and you just start PGE. Because I'm not sure that this particular patient who's already doing unwell and is already hypoxic.
But you should never start PGE in a kid with a large ductus.
I agree, but I think that relates to one of the questions out there. I think there are some of these patients who are already presenting severe hypoxic breast failure, RV, LV dysfunction. You are already on some inotropic support. If the question relates, oh, should we start PGE to avoid ECMO? I don't think your PG is going to make any difference there. So I think that can help in terms of one of the indicators on the echo to tell you, well, yeah, that other intervention, I'm unsure that it's really going to help. Yes, it does have some pulmonary vasodilatory effect, but I don't think it's going to kind of rescue the phenotype at that point if you're already like such in a bad shape. These are my thoughts on that particular question.
No, completely agree. You can't just throw PGE blindly and hope that it works. The Clara's song put a question in there, and we, me and my team argue about this all the time. And I'm just interested to hear what you guys think. Milrinone, again, it depends on the circumstance. You're never going to put anything blindly on, but just overall, thumbs up, your experience has been good, or thumbs neutral, your experience hasn't been the greatest. Because I'll be honest with you, every time I put a kid on Milrinone, this CDH on Milrinone, I end up getting hypotensive, like literally 90% of the time. And I'm not bolusing them. I'm starting them on 0.25. I'm not going high. And then the half-life is so long that now these kids on vasopressin for an additional 12 hours. And everybody that I work with loves milrinone. I think I'm the only one that doesn't like milrinone in this patient population. I think everybody's using it in the country with success except for me.
I don't think we have great data, Amir, to actually, to defend your opinion. I don't think we have yet great data. I personally, locally, we've been users of milrinone in certain phenotypes, but we won't start just milrinone blindly, and exactly for the reason that you outline, like hypotension risk, vasoplegia, renal retention of the drug if you don't have a good renal output, so you can get intoxicated with the drug. So we are very careful about these aspects when we started locally. Like, is the baby peeing? Is the BP maintained? Like, do we have good perfusion? Is lactate okay? And then based on the echo, is this patient, seem to present a more, high PVR picture versus not? And what's happening on the LV side. So if we do have some concern about the LV, that the BP is maintained, renal output for now is maintained, we'll probably start the way you said, like low dose milrinone, no bolus. We've had good experience. Is it the milrinone that, provided that good experience, or is it the rest of the package? I have no idea. We also are high users of hydrocortisone, to be honest, in that population. I don't know what's the kind of experience of others on the board here, about hydrocortisone supplementation when these patients are quite sick, but we're high users of that.
Yeah, we are too. I was going to add regarding milrinone that given the lack of data in babies in this particular population, we are not using open label milrinone because we are part of the trial, Satyan's trial, right? So we are trying to enroll all the infants. So I can't tell. It's going to be an anecdote, what I say.
Sure.
Yeah.
We also had some questions about LV output, and in some babies having very low LV output, but not really having other signs of LV dysfunction. And so one part of the question is, how do you sort of explain that physiologically? And do you try to aggressively treat it or not?
Oh, I see that all the time. Low LV output, but normal EF. Oh, I see it all the time. Why is it? So much right to left shunting through the ductus, small left ventricle. They can have preserved EF with minimal output. That happens quite frequently.
Agree. A lot of the metrics that we use by echo to measure systolic function might look to be preserved, but won't tell us much about the performance of that LV, to be honest. You just outline, the preload is decreased in these patients, which may impact output. Depending on sedation or types of drugs that you use, you may impact heart rate, so that might also influence your output. We know they have smaller LV, they have smaller aorta, so your measurements of output by echo is probably, kind of tinted by the fact that you're measuring a small aortic valve. So there's a lot of these, various elements that can be part of the equation. And I think, when we talk about LV dysfunction, it has to be also comprising of what the interaction with the other ventricle. So I think you outlined, Amir, in your presentation that, at least the group of Dr. Nall who described, the study in INO, they outlined these different phenotypes. But to me, it makes sense that if you have a PFO that's mostly left to right or completely left to right, it's a concern to me if I have a patient with a really big RV and a very big MPA and a right to left shunt at the PDA level, because why would this patient have a PFO that's left to right when theoretically you're underfilling your pulmonary vasculature, which should be underfilling your LA? So it means that there is some backup pressure somewhere into this LA. So in that context, it tells me that there is some degree of left ventricular struggle that is beyond just the high PVR.
Great, makes a lot of sense. Does anybody use other monitoring measures besides echo? Anybody using EC, like electrocardiometry or anything in these patients?
For some of the severe ones, we started using NIRS. And what I'm going to say again is very anecdotal. It's not based on any data of science, but I do think it's, it's interesting to see the pre and post ductal NHRC values. We measure it at the somatic area of the kidney, and we measure it on the frontal area of the brain. Well, I should say the scalp. And I find it gives us some information about like oxygen extraction and trends. And also when we start intervention, it provides us with some sense of like blood flow and directionality of blood flow, especially knowing that there are these shunts and things like that. But, to the point that it would help titrate the therapy to change outcome, I wouldn't go there. Like, I think it's just, we like it because it's an addition to the monitoring we can do at the bedside, especially when, let's say, we're not able to do the echo every 2 hours because we don't want to disturb some of these babies that we know are quite precarious. So how can we get some of this extra physiological information at bedside? So we do look at PaO2. Most of the time we have a postductal sampling because it's in the umbilical artery. So then, you have to be aware that this is reflective of both the atrial and ductal shunting. And we do monitor, the gas, we monitor oxygenation, we monitor lactates and urine output, and we monitor sometimes the NHRC in some of these babies, but that's just our local experience. I don't know for your other centers.
No, we are not currently using anything else.
And following Tina's question, is anyone using lung ultrasound? Because
sorry, what was the question?
For CDH?
Was that the
Do we
question?
use lung ultrasound?
It has been described for surgery planning, and also like what are the characteristics, but as a dynamic tool is in this population. Any experience?
Maky, do you want to answer that?
No, you go. Well, Gabriel and I are just about to start a study on that in Montreal and here at CHOP. So we will see if we can use lung ultrasound to predict outcomes. That's one of our questions, looking at lung recruitment and lung ultrasound scores. And also we want to look at lung ultrasound to see if we can predict extubation failure in CDH. So we don't have any data
But
yet.
it's amazing.
There was one other question about use about the pleural effusions that we know occur after after repair, and that is there ever an indication for draining them at this point?
Yeah, that is a really great question, and it's very controversial. I mean, we have many discussions here. So as you know, there is always some fluid collection post-op, right? Always. Some kids get like much larger pleural effusions than others, right? So when do we drain it? We try to not, first of all, and we try to, just play with the ventilator, the settings, give diuretics, and try to get rid of or improve that with medical management. But when we are unable to really recruit the left lung, supposedly, well, and we are not ventilating well, then that's when we really, we drain the very extreme cases, I would say, very extreme, high CO2, high FiO2, we can come down and we are going up on the settings and still, the effusion is super large. But it's not easy, especially you want to be very careful. I mean, hopefully now people are using muscle flaps for repair more than anything else. But, before with a patch, like you don't want to have, like a tube of plastic there. The risk of infection is huge. So we try to avoid it as much as possible.
Same.
Great.
Same. It's very rare we drain, to be honest. But same approach. It's always a controversy, especially for those severe ones. Like we're not talking about the kid who's born, who's in room air, gets operated at 2 days and goes home at like 1 week of life. I don't think we're talking about these CDH here. I think we're talking about this very severe population. And they typically have the largest, because they have the smallest ex vacuo area to fill up, right? So it's very rare we will touch because physiologically it makes sense. You have an empty cavity, it will get filled with pleural fluid. But
Yep.
I'm saying it as if it's a simple, but it's always a controversial topic.
Yep. Great. I think we've gotten through a lot of the questions, and we know that some of you have to go. So I think this is a reasonable stopping point, if that's okay for everyone. And want to thank you all so much. It was a wonderful discussion and really great talk, Amir. I think the audience all agrees, and it was very helpful for everybody involved.
Thank you so much. It's an absolute pleasure. Thanks to the panelists.
Thank you for having
Thanks.
us.
Yeah, thank you so much.
Thank you so much.
Good to see you.
Bye-bye.
Good to